I request Dr. V. Mohan sir, diabetic retinopathy in the eye of a diabetologist. Whose responsibility is it to screen for DR? To enlighten us on this topic, we have with us Dr. V. Mohan sir, Chairman and Chief Diabetologist, Dr. Mohan's Diabetes Specialty Center, WHO Collaborating Center for National Non-Communicable Diseases, Director and Chief of Diabetes Research, Madras Diabetic Research Foundation, and ICMR Center for Advanced Research on Diabetes. Sir has a multitude of academic qualifications and fellowships conferred on him, with 1,132 publications, 721 original research articles, and 54,037 citations, and numerous chapters in textbooks. His contribution to this field is gigantic. The doyen of diabetology, his resplendent work is an inspiration to all in the medical fraternity. We are pleased to have you with us, sir, today.
Okay, I'd like to thank all the organizers, Dr. Shobha Shivprasad, Dr. Rajiv Raman. It's been a wonderful meeting, I think 2 full days. In fact, my daughter was asking, why are you spending so much of time with retinopathy? I said, I want to learn retinopathy. And I've learned a lot during these 2 days. And congratulations to the whole Ornate India team. So the question which Rajiv wanted me to talk about is diabetic retinopathy in the eye of the diabetologist. Whose responsibility is it to screen for diabetes? I think we've been for retinopathy, and we've been discussing this quite a bit from yesterday. Now, just to set the context, now these are the latest numbers from the IDF Diabetes Atlas 10th edition, which was released every 2 years. The IDF releases the new data. And quite surprisingly, in 2019, we had 77 million. So my prediction was 80 million. Every 2 years, every year 1 million gets added. So I was expecting 80 million. Then they reduced it to 74 million. So I wrote to the IDF committee and said, what do you think? Diabetes going down in India or what? Next year you'll tell us it's only 40 million or something. And they said, no, it's based on your published results. So what happened was the INDIAB study is going on, and in the first 15 states, we had all the northeast states. So we had 6 or 7 northeast states which have very low prevalence of diabetes. So based on that, they extrapolated and they said, oh, India's numbers are a little smaller. Now the next 15 states are going to go up, where Kerala, Goa, and so on, it's in excess of 20%. 20 to 24% is the prevalence of diabetes in Kerala, the whole state, not city. Whole state, including rural and so on. So next year, they'll hike up the numbers. So what I'm trying to say, these are all just a committee sitting down together, doing some maths and putting some numbers. Problem is, we do have a lot of people with diabetes. And these numbers, which are supposed to go up to 124 million after 24 years and so on, is obviously underestimated. There will be much, much more than that, because India will be a much older population by that time. And age itself is a non-modifiable risk factor. We'll be much older. We'll be having at least 10 years more lifespan by that time, if not more. So anyway, we have a lot of work to do, all of us. And so it's not a question of whether diabetologists will screen or ophthalmologists will screen. I would say even the Gurkha can screen, he can also screen. Everybody should screen so that we ultimately reach the goal. Because I think we all have to pitch in. But having said that, this point we have been discussing ad nauseum from yesterday, that people go to the ophthalmologist only if they have symptoms. It's not like, even to dentists, they go only when they have a pain in the tooth. Even if you tell them every year come and all, how many will come? Well, I'm okay, no, why should I go and see? So similarly to ophthalmologists, every year you come and do an eye test and all that. Even if they have symptoms, they don't come. So to a diabetologist physician, they're supposed to go. If you ask me what is the follow-up rate, we have like 40-50% follow-up rate at our center. If you push it, we may get 60. 40% of them don't even come back. They just come for once and that's it. After 10 years, 15 years, they'll come back with an old prescription. Some of those drugs will be totally outdated. You only wrote it, they'll say. Yeah, I wrote it 15 years ago. Things change in medicine in 15 years' time, But still there is an opportunity screening possibility there. And so we should not lose that opportunity when they come. We even thought of doing something strange, with this COVID vaccination, when people take the thing and then they have to wait for 30 minutes. We said, why don't do a retinal examination, retinal photograph we can take for everyone. While they're waiting, they're doing nothing. Why don't you just take a camera and take everybody's, pictures? So you must make use of every opportunity. And the other thing is, of course, that diabetic retinopathy can be prevented by good control of diabetes. And that is, again, with the diabetologist. So are we achieving good control in India? Just to let you know where we are. Now, this is a study which we did in 2001, we did it, and then 2011, we again repeated it. This is done among some of the who is who of diabetology and endocrinology you will find in the country. You will find names like Shashank Joshi and Sheshaya, Samar Banerjee, across the country, Sanjay Kalra, A.G. Unikrishnan, Ashok Kumar Das. So when we did it in 2001, this is across diabetic clinics and endocrine clinics. So you think that the best care will be available there. The mean A1C across India, large sample size, was 8.7. So 10 years later, when we repeated, we thought, it's going to get much better. It was 8.9. It's become worse. Now, why did it become worse is a question that you can ask me. Maybe the worst cases are going there, because they may be getting referrals from all the bad cases, and this may not be India's true story, which is true. Clinic-based data has a lot of bias. But this is what we got then, and this is what we got later. If you want to get India's data, you must go to India. So you must go to every state, must do a representative sample, urban, rural, proper sampling being done. And that's what the ICMR INDIAB study is all about. It is the world's largest diabetes study ever done. 124,000 people, representative of India's 1.36 billion people. Totally representative. So you take the census graph and put the INDIAB graph on that, you will get exactly the same. For every state in India, it's been done. Very thoroughly checked by ICMR with field visits and quality checks and so on. This is an early paper which we published when we finished 4 states in India. And roughly the same pattern has remained even at the end of the study. So, and this is what it is. If you take A1C less than 7 as being good control, 7 to 9 as, say, fair control, and above 9 as very poor control, only 31% of urban Indians and 30% of rural Indians had good control. That means 70% of Indians are not having control. Now, this is not referral bias. We have gone to their homes. We have done representative sample. We have picked one person from each home. It can't be more representative than that. If you go to the other end of the spectrum and go to those who are above 9%, now these are people who are definitely going to get complications. I don't have to tell you that A1C is more than 9%, they will get complications. 37% of people in rural India and almost 32% of people in urban India have A1C above 9%. We are not at all doing well. We've got a lot of work to do. Now you may say some of the states which have the best indices, maternal mortality, take Kerala. Is it better? No, it's the same. It's not that they are doing any better. No state is better than the other. We cannot say one state did very well and the other did poorly. All are bad as far as diabetes is concerned. There could be 1%, 2% differences. It doesn't make much of a difference. We also know that with poor glycemic control, the risk of all complications increase, not just retinopathy, nephropathy, neuropathy, even cardiovascular disease. Although for cardiovascular disease, hypertension and dyslipidemia and blood pressure and smoking and weight and other things get added on. But glucose is certainly one of the factors which adds to the complications. So both microvascular as well as macrovascular complications go up. And the higher the A1C, the more the complications. And these are some of our own data on all the complications. We have data for rural Tamil Nadu as well as urban Tamil Nadu with respect to coronary artery disease, peripheral vascular disease, retinopathy, nephropathy, neuropathy. And these figures are very similar to SN Dreams or Arvind's data or LV Prasad data, which I remember Shobha talking many years ago in a meeting before Ornate started. How come all are reporting the same rates, and this is very much lower, because much lower than what Eva Connor reported in UK or UK PDS and so on, which is reporting 35%. We are talking about 17%, 18%, 19%. All the studies came in the same range, and even now we are getting the same in Ornate India. But given the large numbers of people with diabetes in India, Shobha also mentioned a figure yesterday that they have 4 million people with diabetes in UK. And she also said we have 4 million people with retinopathy in India. So it's huge. And if you take the diabetic population in India, it's more than the UK's population now. Okay? It's 3 times Australia's population. So we have, whatever you do or try to do, what you can achieve in Mauritius or Australia, we are not able to achieve in India because of the sheer magnitude of the problem. You take diabetic kidney disease. Now, 20 million people in India already have microalbuminuria and above. Now, even if a third of them land in end-stage renal failure, you're talking about 5 million people who need a transplant or dialysis. Are you going to get 5 million kidneys to do dialysis? You can't get 5,000 kidneys in a year. So it's a futile exercise. If you're trying to provide treatment and dialysis to 5 million people and all that 3 times a week, there's 15 million dialysis, you're not going to do it. You're simply not able to do it. So the only thing that we can do is to prevent it. At least prevent the end stage of complications. And that's why 2 years ago in World Diabetes Day, I gave a plea and I said, I dream of an India which is diabetes complications free. I'm not saying that one microaneurysm should not be there, or after 30 years, little microalbuminuria should not be there. But no blindness, no kidney disease end stage, heart attacks come down drastically, no amputations due to diabetes. If we're able to achieve that, I think it's eminently doable. And we just focus on that one A1C 7% with almost with a paranoid vision. If we're able to do that, 3 complications, retinopathy, nephropathy, and neuropathy, at least you'll be able to reduce. Okay? But what happens is, and this is again something which Rajiv mentioned and others also mentioned, very few people get to 7%. And once they get to 7%, they think, now I've got 100 out of 100, so I don't need to come back again. Okay? So what happens is, they delay their, is there a pointer? I can't find it. Okay. So they delay their coming to the clinic. And as they delay the coming to the clinic, A1C will go up. So we need sustainability. It's not 7% once in your life you achieve it and you'll prevent complication. 7% throughout your life you have to maintain. That's what I said, the Swedish data. Those who maintain below 7%, not one developed kidney disease or eye complications. It's remarkable, isn't it? In a country where you can say that not even one developed, I'm not saying whole of Sweden achieved it, but those who achieved it, not even one got it. So that's proof for us. Now, this is what happens. You accumulate what's called as a glycemic burden. And that glycemic burden, through many mechanisms, whether it's orbital pathway or age pathway or hexosomal pathway, you can debate that. But through some biochemical pathways, it gets imprinted on your retina and your kidney and your nerves and your heart, and is now saying, now you develop retinopathy. It's already the signal is given. And once it is given, you can't take it back because the process already started. Maybe in early stages, you can still try to reverse, but once it goes off, you've already opened the barn door and everything has run away. You can't get them back. So what do? This is I'm talking about, it's a hypothetical situation, but I've got exact data in the clinic published to show you that this is not hypothetical, it's true. This I'm talking about, let's say, 2-year follow-up. If they don't come back, that's the amount of glycemic burden that they'll have. What if they came back after a year? Then what happens is, that much is unavoidable because they came back only after a year, shown in green, but the red is avoidable if they had come back. What if they came back after 6 months, or 4 months, or 3 months? Then you can reduce that unavoidable burden, and the rest of it is totally avoidable. You can reduce avoidable burden, and the unavoidable burden is so small that you will bring it down again. It's not going to be long. Within 2 months, you've seen A1C go to 7.5, you brought down to 7 again. Again, go 7.3, again you brought to 7. So the average is going to remain around 7, and you're not going to get complications. I think it's doable if we all put our mind to it. So now let me come to the DMDSC model of diabetic retinopathy screening. When we first started, we had only one clinic. So Rama was ophthalmologist, then Raji and others joined. We now have 6, 7, 8. How many do you have, Raji? 8 ophthalmologists we have. But then we started expanding. Now we are in 32 cities. We have 50 centers. How can you get 50 ophthalmologists? First of all, we can't afford them in the smaller clinics. And it's not cost effective also. They won't have enough work also. So then we said, okay, but we still have to screen the eyes of all patients type 2 diabetes at the time of diagnosis and annually thereafter. And in type 1 diabetes, first one after 5 years and annually thereafter. Are we achieving this? No way. Patients don't come back. They don't come back, how are you going to do it? They come back, you have a chance. Even then they'll refuse. They'll say, no, I'll do next time. And then what do you do now? Okay? So these are some of the experiments, primarily led by Raji, and she has presented these in several forums. This is validation of the smartphone retinal-based photography to see whether using low-cost devices which are handy, whether you can use it in smaller centers. And that went quite well. Then, of course, using artificial intelligence, all of you have pioneered and used. We've also done this using automated diabetic retinopathy and smartphone. Can this help in some way the ophthalmologist to do the screening? And then we've also looked at, as part of this project, using renal function as a starting point. So can you take those who have kidney disease, and will that at least predict STDR or VTDR? So that's the one we're interested in. We're not interested in one microaneurysm here or there, but we're interested in those who are going to lose vision. Can you do that? There's a beautiful correlation. So if you take nephropathy as a marker, which is so easy to do, even a dipstick you can do. Clinical proteinuria, you can even use as a dipstick, which you can use it anywhere, point of care, can do it. You can do microalbuminuria with point of care devices today, which we have used. So using that, what we found was, at least those who have some kidney problem, earliest kidney, microalbuminuria or above, you will be able to pick up a large number of people with sight-threatening retinopathy. That's what came out from this paper. And then the next experiment we did was, okay, if you don't have ophthalmologists, can you do some kind of a remote thing, which Arvind, Shankar Netralia, all have been doing, LV Prasad, all have been doing for years. But we said within our system itself, there are centers where there's no ophthalmologist. Can we start doing telemedicine to see, not just for retinopathy, but also for other complications? That's what this paper showed. And then we started putting it all together and saying that if you use a van and then go to rural areas, can we get the van and can it be fed back into the system? Can we use handheld devices as we used in the ornate study, the A1C now, where you can get A1C also, you can get glucometers, you can get blood pressures, you can use low-cost things like biothiometry. All this can be put, ECG is easy to get now. So can you put it all into a van and then go around villages? Very successful project. We even use the IDRS, or the Indian Diabetes Risk Score, which again we use in the ornate project, to screen out people in a population. Again, you can't go and screen everyone in a population. Can you use the risk score to identify who will have diabetes, and then those who have diabetes, at least you do screen the eyes. Okay, that experiment also worked well. This is the latest paper and got actually published last night. And I sent it to Shobha and said, great, just then came for the meeting. It's become online yesterday in DTT. So this is an experiment which we tried. We have all our centers, and most of our centers have a retinal camera. Almost all, none of the small centers have an optometrist because we can't afford them. Some of them have, some of them don't have. So what we have done is, in the big cities, in Chennai and Hyderabad and other big cities where we have ophthalmologists, we have retinal specialists, they can do the grading and they can send the pictures. So can we have a hub and spoke model where the smaller centers take the pictures and send it, and within about less than an hour, they get the result back. So the diabetologist takes the picture. First thing we do is after taking the fasting sample, and we give them some breakfast and then take the picture first. And then while they're going through the rest of the tests, the pictures have come to one of our big centers where Raji and others will grade it, send the pictures back, and now the diabetologist there is having the picture and talking to the patient and saying, this is what our ophthalmologist in Chennai said, or Hyderabad said, or Coimbatore said. And so we have divided them like that. It worked beautifully. So we wanted to compare in this particular study, which was also included as part of this study with Shobha's help. So we wanted to do a retrospective study and say, in the places where they came face-to-face, like in Gopalapuram or one of the Chennai centers where we have ophthalmologists, as compared to a remote place, how did they do? And here are the results. Now, when you do teleophthalmology, the NEDR came to 31.7%. It was 38.5% when you do the fundus exam by the retinal specialist, because they're, in addition, doing the fundus exam, plus they're taking the pictures, slightly more. So if you look for statistical significance, you might find statistical significance. But my point is, when that is not possible, you've got still 31% picked up by teleophthalmology, where there was no ophthalmologist and no optometrist also. Similarly, if you look at the sight-threatening also, of course, it will be a little bit more. It could also reflect referral bias, because those centers which have the ophthalmologist, more sight-threatening could have gone there. So you can't rule that out as well. But the point is that you're picking up sight-threatening retinopathy as well, without an ophthalmologist in-house. So this has been our experience that diabetic retinopathy is feasible and effective for sight-threatening detection of STDR. Screening for retinopathy in a clinic rather than in a camp or in an eye hospital is a good method going forward. There are thousands of diabetic clinics in India. The question is, how do we incentivize all of them and get them interested? But if you do that, I think a large number of people, I'm sure millions of patients are going to these clinics, and we can do that. Of course, holistic screening for all complications possible in this mode, because automatically we have the others already possible there. And I would like to call this as a DMDSC, diabetologist, ophthalmologist hybrid model, where the ophthalmologist is also there, the diabetologist is also there, and we're trying to put both of it together. And only those who need referral needs to be referred. Again, I'm not saying that all those who needed referral we were able to refer, or in many cities where we don't have an ophthalmologist, we ask them to go to other centers. I don't know whether they went, because there's no method of following up everybody in this country, because this is not NHS or any other system where they have to come back to us. They do window shopping from there, they'd have gone somewhere else also. They'd have changed the diabetologist also. So, but still, with all its limitations, we still feel it's a model which can be adopted in India. So these are my take-home messages. Patients go to ophthalmologists usually after they develop symptoms. In a diabetic clinic, screening for all complications can be done. Diabetologists have a unique opportunity to screen for retinopathy. Thus, the diabetic clinic provides an opportunity for screening, detecting, and treating diabetic retinopathy early. And I think if we do this properly and sincerely, blindness due to diabetic retinopathy can come down in this country. Thank you.
Thank you, sir.
No questions, huh?
How often do you recommend checking HbA1c? I mean, what should we be telling?
Ideally 3 months, but again, in an ideal world, that's not always there. So at least twice a year, if they do it, I think it is good. Less than that is really once a year. If you check and find it's 12%, you have that glycemic burden you've not been able to. So if they are coming once in 3 months or 4 months, A1C will be routine for us. So once in 3 months, if you do, it's more than enough. At least twice a year, if you do, it should be the minimum.
The rural-urban divide, everywhere else, is it just down to a simplistic factor like lifestyle and urban lifestyle, or is it something else?
So cardiovascular, we are still analyzing our data, and it's not very robust in INDIAB because all we had is ECG. So 12-lead ECG, Minnesota coding, that's all we're trying to do. Very insensitive, we don't have treadmill, we don't have echo, we don't have anything else. So cardiovascular pickup rate will not be very good. But you're absolutely right that in urban areas, you would expect the cardiovascular rates to be much higher because of stress and obesity being more and various other factors. In rural areas, I suppose there would be more physical activity. Their diet will be a little bit more frugal. Their obesity rates are much lower. So we would expect cardiovascular rates to be lower. But then Kerala is, again, a good example. No? There's no urban-rural divide at all. And this is happening in many, many states now. Tamil Nadu is 50% urbanized now, and 50% is rural now. So it's very rapidly happening that this urban-rural divide is going to go. And then all the junk foods which come here, it goes there. And we have tried doing this to rural areas. No? So we made this mistake. So we were drinking Coke and we were drinking this and that and all that. So you don't make the same mistake. You know what is their answer? You enjoyed it, no, for 10 years. Now let us enjoy it. We have been waiting for this, watching TV all these years. We were waiting for Coke to come. Now when it comes here, telling us not to take, So they are not ready to do that. Similarly, the concept of walking. When you first went to the villages and said, walk. What is that, walking? We are always walking. We are working in the field. But today it's changed. Now they're sitting on tractors and going. So they have to walk today. Yes, Padma?
I think it's actually very inspiring to see your model, which is the ideal combination model. But I think the economics of it, if it's published and if it's also more advocated, that having an ophthalmologist set up in a diabetes center at a tertiary level and at the primary level through teleophthalmology, this whole thing, economics also, if it can be advocated in all RSSDA and all, I think we will achieve fundus cameras in many places.
If you're talking about cost effectiveness, that is one of the criticism of our Chunampet rural model, because that van was so expensive. There's no way it's going to be cost effective for the number of people with diabetes you picked up and the number of eyes you saved. It's very small. So for the amount of money that you spent on that van, it is not cost effective. But I don't think cost effectiveness is only dollars and rupees that you should see. It's also quality of life, and it's a right of people. And therefore, I think some of these costs should be absorbed and should not be taken as a cost at all. It's a right to the people not to lose vision. If one person loses the vision, can you say, oh, that's equal to 1,000 rupees? You can't. There's no value for it. No. So certain things can't be measured. But you're right. You must show, at least from the popularizing, from the doctor's point of view, that they can make money out of it.
No,
I'm
my
sure they
idea
can make
is not
money
about mobile vans.
Yeah.
My idea is about having your permanent setup in your centers.
I don't see why doctors are not accepting that. I can't believe that. Once you get a camera, it's a fixed cost. And then if you start, screening more and more, it will definitely become cost effective. There's very little running cost in that. No? Yes, Shobha?
And if we add that to the screening program here,
Correct.
the cost is exorbitant.
Okay.
So then it becomes very cost effective.
Yeah.
Because now, for Kerala model, we are saying it's 400 rupees for a screen per patient. But we haven't accommodated the fact that a proportion of patients are going to go blind.
Correct.
All their social care, etc. When
Correct.
you add that into the model, it's much
I think it
cheaper.
will become cost effective. I think UK and other examples have already shown that. Yes, sir.
Yeah, so we see a lot of stress on HbA1c, but on ground, it's not possible to have all our patients run through HbA1c. So can we think of an alternative like RBS or fasting blood sugar? Which one is more reliable amongst all those three, meaning fasting, random, and postprandial?
All are good. But the problem is that they vary from day to day. So today you're fasting, we had a sumptuous meal, including my dessert and the gajar halwa that I've had there. Definitely my after breakfast will be higher than my usual lunch. So then you need averages. That average is HbA1c. So that is where the HbA1c helps. Today we've got continuous glucose monitoring. So you can just put a small patch, and that's going to give you 100 blood sugars in a day. It's going to give you graphs, okay? And they're not very expensive. It's 2,000 rupees. For 14 days, 1,400 readings you're getting. It's like 1.5 rupees for a reading, okay? You don't have to put it all the time. We are now promoting intermittent use of that. Use it once in 6 months. That's enough. You'll get a pattern for 14 days, 100 blood sugars in a day. And those are much, much better than measuring one blood glucose here and one fasting here. If you measure after breakfast, what about after lunch? What about after dinner? That may be your highest thing. So you have to test so many times a day. If you see the cost of that and you see the, the pricks that you have to go through, the pain you have to go through, and you're still getting snapshots only. It's like taking photographs. Here is like getting a video of the continuous glucose monitoring. So I think these things have come to stay. The cost can be brought down by reducing the number of tests that you do. For example, HbA1c is not able to do it 4 times a year, do it 2 times a year. But still don't get rid of the test, because the test is still a gold standard. Because with complications, that's the only test which has been validated, not fasting blood sugar or postprandial blood sugar. So HbA1c has been used in DCCT, UK, PDS, and all other studies. So it is still a gold standard only.
Okay, so another idea about bridging the gap between the ophthalmologists and diabetologists. Yeah. We know that we go to the registration office for renewal.
Yeah.
So when we go to the registration office for renewal, if it can be a policy in India that before you renew, you need to have some kind of a competency to
drive a car or to drive
no, kind of meaning you should be having some collaboration with an ophthalmologist or...
Oh, you mean registration of the center?
Yes, yes. So unless the diabetologist passes through that, you are not given that renewal. Meaning...
So, he's talking about registration of the clinic itself. Now, that's a big step, yeah. I think we should do it more voluntarily to start with. They'll say there's no ophthalmologist here. How can I collaborate? Something will come. So instead of that, focus that time and effort on education. Education. Then you can do it. Rajiv, you are about to ask something.
Just wanted to know, we've been always talking about HbA1c as an important risk marker. How about glycemic variability? Whether that is better, that is more, or HbA1c is a better marker?
So glycemic variability, the number of studies which have come, mostly Monier's studies from France, and they have shown that the more glycemic variability you have, the more oxidant stress comes. And that mostly his own studies. And mostly for cardiovascular, less for microvascular. But today, from the continuous glucose monitoring, we have, it's not glycemic variability, it's time in range. We call it as TIR. So 70 is a lower limit, 180 is upper limit, and within that, if you have your time in range. Anything above that is time above range, TIR. Anything below 70 is time below range, TBR. So if you have 70% time in range, that means if 70% of the minutes of the day or hours of the day you are under control, you will get a HbA1c of 7%. Okay? If it's 80, it will become 6.5. If it's 100, it will be 5.6 or something. And if you go to 60, HbA1c will go up. Now, for every 10% decrease in the time in range, retinopathy goes up by, and nephropathy goes up by 40%. So from 70, if you go to 60, your risk has increased by 40%. So time in range is a fantastic tool. So we actually use fasting and post-meal blood sugar, HbA1c, and time in range. All the four, because all four give different. HbA1c tells you that your average has not been good. It doesn't tell you what to adjust. If you get a value of 11, what does it mean? Which one you're going to adjust? Your tablet, insulin, diet, which one? For that, you need either fasting blood sugar or post-meal blood sugar or after dinner blood sugar, or still better, this time in range and continuous glucose. Then you know exactly which one to adjust. Statins. I am a great believer. So I believe that there are more than 40 to 50 trials which have been done. So I think people should take statins when indicated. Some people have gone overboard by giving, statins is not needed, and very high doses of statins, which have resulted in myopathy, and even a small increase in diabetes, new onset diabetes has been reported after statin. But all said and done, the benefits outweigh the risk. So I think statins should be used, if indicated.
Can I add something?
Yes, yes.
So, to answer your question about HbA1c, sir, for example, you post a patient for cataract surgery, and he comes to you with a fasting of 120, post-meal of 180. But then you get an HbA1c, then it comes out to be 10. So what has happened is, patients are knowledgeable. They will control their diet and take the medicines when they want to come to you, but they may not be doing it. Chronic medicine has a default ratio of 50%. So you base your treatment and your surgery on the basis of HbA1c rather than that fasting and post-meal on that day. So that is why I think we are looking forward. We want everybody to have a fundus examination. We should all tell our patients to have A1C at least every 4 monthly. Only then you would be able to give them proper diabetes care.
Agreed. We'll stop. Rest of time. Thank you. Thank you.